Hi, everybody. I hope you can hear me now. Sorry for the technical glitch. Welcome to this afternoon's sessions sponsored by Boston Scientific, entitled Beginning with the End in Mind. My name is Tan Hui Chim, and I'm from the National University Heart Centre, Singapore. And the session objectives for this afternoon include the following. We want to explore the different plaque modification techniques and technology available currently. Number two, we also want to talk about maximizing the PCI outcomes with intravascular ultrasound imaging. And thirdly, we also want to talk about the leveraging of FFR in determining whether to treat versus intravascular ultrasound imaging to determine where and how to treat. So really a context between physiologic and anatomic assessment. So for this afternoon sessions, I'm pleased to have with me as moderator as Dr. Adrian Loh on my right side. And further to my right is Dr. Ahmad Fauzi Yahya from Bandung, Indonesia. And on my left is Dr. Viraj from Thailand. And we also have two remote discussants that are connected to us from all the way from China, one of which Guo Ning, and the other one is Zhang Junjie. So I'd like to encourage all of you here to really participate and interact with us. So we do have a chat box here in the AICT-AsiaPCR 2022 web link. So feel free to ask any questions. We will try to answer your questions as much as we can. There is a chat master who will be interacting with you directly, and that's Dr. Sim Hui Wen, also from the National University Heart Centre. So I think to begin with the entire session, I'd now like to invite Dr. Guo Ning, all the way from China, to talk to us when and where to use FFR. Guo Ning, please.
Okay, thank you, Dr. Chen, and it's a pleasure to see you, from the internet. And hello, early doctors. So today I will talk about one is as important as their practical application of FFR during PCI. So far, FFR has been used very widely to evaluate single intermediate lesion assessment, but it already expanded to a lot of scenarios like multivessel disease, tandem lesions, diffuse disease, Leffman, and non-Leffman bifurcation disease, the DCB in de novo lesions, CTO, ACS, INOCA, etc. So I will talk about a few of them because of the time limitation. And first, let's talk about the tandem lesions and the diffuse disease. So if we look at both LAD of the two cases, and you can see very diffuse lesion. But if we look at the FFR curve, it's very different. For first one, we can see two significant gradient on the FFR curve. And the second one, we didn't see this kind of significant gradient. So actually, for this very diffuse lesion and tandem lesion, FFR can be used to evaluate very accurately the functional significance of each individual lesions within one vessel. And how to do that? We can do pullback pressure recording. And if there is no significant pressure gradient in a diffuse disease vessel, maybe CABG is better a choice. This is from our Chinese expert consensus on clinical pathway of fractional flow reserve measurement technology. And also sometimes combined with distal FFR value, patient's chief complaint, age, and other complications to make a judgment like intravascular imaging should be considered. And here we can see two representative cases of this pullback, or we call it a delta FFR usage and its application. So both LAD have two lesions, lesions A and lesions B. So for the first case, when we do FFR pullback, and we can see two delta B FFR is more than delta FFR of lesion A. So firstly, we treat the distal lesion, and we test the FFR again, and we got a negative FFR value. So lesion A was deferred. And the second case, we can see there are also delta FFR of lesion A is more than lesion B. So treat lesion A firstly and retest the FFR. And we can still get a positive FFR. So PCI for signal B was finally performed. So this is how we use the delta FFR or playback way for this kind of tandem lesions. But notice when considering serial or tandem stenosis FFR calculation by simply measuring the hypoischemic pressure proximal and distal to the lesion may cause underestimation of functional significance of individual lesions because of the impact that serial lesion has on the flow across the index lesion. How about left-hand lesion? According to the ACC 2017 AUC for coronary revascularization in patients with stable ischemic heart disease, and for the left-hand MLA between 6 and 7.5 square millimeter requires further physiological assessment such as FFR. And alternatively, FFR may be used as a first modality to assess ambitious left-main severity. And here we can see routine use of FFR to get treatment of left-main coronary artery lesion was associated with almost 29% reduction in CABG and 19% increase in PCI. And how about the safety of deferred left-main lesion according to FFR? And we can see this is long-term outcomes following FFR-guided treatment of angiographically ambitious left-main disease. And in these 6 prospective cohort studies involving 525 patients, and the long-term clinical outcome in patients with ambitious left-main stenosis is deferred based on FFR are very favorable and similar to the revascular group in terms of overall mortality and subsequent myocardial infarctions. But the problem of FFR for left-main lesions is that it may influenced by downstream coronary artery stenosis. So possibly we can get false negative or false positive FFR value. So at this point, there's a study showed in the presence of proximal mild or to moderate LD or LCX disease, like composite FFR more than 0.65 in animal or more than 0.45 in human, and the left FFR can be reliably measured with a pressure wire placed in the uninvolved epicardial artery. So this is a representative case, and this is we can see a mid-LD lesion and intermediate distal left lesion, and treat the mid-LD first, and from IVUS we can see very intermediate lesion from distal left main to osteo-ILD. At this point, and we test the FFR for the circ, and we got a negative FFR. So this left main was deferred. And also for the distal left main bifurcation lesion, morphology, no matter angio or IVUS cannot predict jailed circ FFR after left main to LAD crossover standing. How about lung left main bifurcation lesions? Actually, FFR-guided lung left main bifurcation lesions intervention, we can use it from both pre and post intervention for the both main vessel to the post main vessel. And as the EBC consensus recommended, after sending of the main branch, FFR more than 0.8 of the side branch indicates that it's safe not to intervene the side branch. And angiographic stenosis of jailed side branch after main vessel crossover standing cannot predict its functional significance according to many studies. previously. And the FFR-guided side branch intervention strategy significantly reduced the unnecessary procedures and result in very good functional outcomes. And this is a representative case of FFR-guided side branch intervention after main vessel crossover staining. This is before for the diagonal 0.77 and then crossover and geode diagonal down to the 0.72 and after kissing balloon and it increased to 0.89. For the ACS patient, nowadays many studies show that we can use the FFR for the non-corporate vessel of no matter STEMI or non-STEMI or a patient, no matter its acute phase or chronic phase. But for the acute phase of STEMI, it cannot recommend it to the corporate vessel. And for the post-PCI FFR value, also a lot of studies have showed very low post-PCI value predict very bad outcome. And as this meta-analysis showed, post-PCI FFR more than 0.9 is associated with less 10% risk of repeat PCI, and also higher the post-PCI FFR value, the lower risk of MACE. And here we can see this very simple schematic approach of interpretation of post-PCI FFR. And if we got a suboptimal post-FFR, maybe we need to assess for the mechanism. If we, from the pullback, we can find a second lesion, we find under expansion, hematoma, something like that, and we can treat with another standard of further post-dilatation. And also we can use intravascular imaging to help us find the mechanism of suboptimal post-PCI FFR. And if this from pullback, this is very diffuse, the distal lesion, and this is not likely to improve post-PCI FFR. So in summary, FFR has become the gold standard in assessing the functional significance of coronary lesions. And FFR can be applied in many clinical indications, from stable angina extended to unstable angina, non-STEMI, STEMI, from borderline lesions to multivessel disease, diffuse disease, bifurcation, and Leffman disease, and from pre-PCI to post-PCI. Thanks for your attention.
Thank you. Thank you very much, Guoning, for your very comprehensive talk on FFR applications in clinical settings. So we're going to have some discussions among ourselves here. Maybe I just want to ask Adrian, so you know the FFR is really requires some kind of vasodilator to induce to bring about maximal hyperemia and reduce the peripheral resistance. What do you think is the role of non-hyperemic pressure ratio nowadays in the presence of FFR? We know that in the Boston COMET system, they also have this DFR index that you can use. So can you share with us what's your thoughts on the FFR versus the traditional FFR versus the non-hyperemic index?
Yeah, that's an excellent point, Hui-Jim. I think that has been a lot of interest in the use of non-hyperemic pressure ratios, mainly because of its convenience and not having to use hyperemia, which is an advantage for a lot of labs, because the nurses will have to prepare it and you may have to deal with the potential side effects from its use. And the reason why it has taken on a surge is because largely because of two publications in New England Journal of Medicine that suggest that it is non-inferior. But there are some methodological issues with those trials, albeit it's published in reputed journals. And I think subsequent to the publications, what is now known from common practice is that in a fifth of the cases, so about 20% of cases, you're going to have some discordance from the FFR. And the question then is, which one do you trust? I think that's really the issue here, that although the non-hyperemic pressure ratios, which are generally considered to be equivalent, whether you're using the first one, which is the IFR, and the various non-hyperemic pressure ratios from the generic PDPA to the various proprietary algorithms, they are all basically equivalent based on all the published studies so far. I personally, in my practice, I still rely on FFR, mainly because I go beyond just evaluating FFR. Usually in my practice, I like also to look at the CFR, the IMR, and now there are some other new emerging markers that provide me with a little bit more information. And for the select patient, that additional information can actually help me in deciding what is the likely response of the patient to treatment, as well as to guide me in how I might want to manage this patient. So in my practice, at least, I still rely on FFR, albeit there are rare situations where I might just rely on a RAS PDPA ratio, but only if it is clearly abnormal, certainly not in a borderline situation.
Thanks. Dr. Guoning talked about a post-PCI FFR more than 0.9. Actually, it's a very difficult situation to be in, because it's not easy to get a post-PCI more than 0.9, and if you can get a 0.87, it's pretty good already. So, and plus, she actually shared a meta-analysis that suggested that maybe post-PCI or more than 0.9 has some kind of beneficial clinical outcomes. But yet, in some of the randomized clinical trial, like FFR search or target FFR, it doesn't seem to work very well. So, Viraj, do we aim for a post-PCI FFR more than 0.9? Should we do it in clinical setting? Is that what you go for if you were to use FFR?
I agree with you that it's quite difficult to make the goal of the high FFR after PCI, especially in the diffuse complex lesion. So in some cases, even we try to tailor the stent size under the IVUS to the adequate parameter. The FFR still not reach the goal. So in such a case, sometimes we have to accept below the goal of the FFR. And I think that this should be some issue that we need further study or the bigger data. Yeah.
The use of physiologic assessment continues to be quite low in this part of the world, particularly in developing countries and so forth. So, Fauzi, do you use a lot of FFR in your practice? And in a system where it is constrained by resources, who do you think will be the best patients to benefit from the use of FFR in your practice?
Thank you. Most of the patients came to our hospital is either ACS or they already have a non-invasive assessments, functional assessment. The problem is if the patient coming with the triple vessel disease. So we treat the severe stenosis in regard to 90%, and the other one we measure the FFR. So thanks God, then our hospital is supported.
So reimbursement is not an issue here.
Yeah. But some other parts still have a big issue.
Okay. So thank you very much. I think we are quite happy with this current cover of FFR. Now, I would like to invite Dr. Adrian Loh here to share with us a case that he did at National University Heart Center. And then we're going to look at this case together and see how we can learn from this case of IVUS-guided plaque modifications of calcified stenosis. So, Adrian, I'm just going to let you take over here.
Sure, thanks. Thanks, Richard. Let me just load the case here. So the patient that I will be sharing with you today basically is a segue from what we've talked earlier about using FFR to decide when you should treat the lesion. But now, having decided that a lesion requires treatment, I hope to just share with you via this case how intravascular imaging can be helpful in guiding you in treating the patient. So we have a middle-aged man, basically of appropriate weight and height, background risk factors of hypertension, diabetes, elevated cholesterol, as well as end-stage renal failure and hemodialysis. So whenever you hear this term end-stage renal failure, you know what's coming up. The patient actually would have expected to have quite significant coronary artery disease, in particular calcified vessels. So this is the right coronary artery that you can see here. But for today's session, we will be focusing mainly in the left system. And this is the RAO caudal projection followed by the AP cranial. You see that the patient has very extensive calcified disease involving the LAD as well as the distal left main. And you can see from the panel on the right that the LAD is diffusely diseased with an ectatic segment in the proximal to mid LAD, as well as a very diffuse, possibly subtotal occlusion of the distal LAD. So as is usual, we have a hard team discussion on what is the best treatment for this patient. And the patient was actually evaluated by the surgeons, but the surgeons were not keen to offer bypass surgery in view of the diffuse LAD disease and what they deemed to be poor distal target. So the patient ended back up with us with a planned complex PCI. So over the next couple of minutes, I will be sharing with you how IVUS might be helpful in gauging the lesion as well as helping you in lesion preparation, as well as an approach to treating calcified lesions, which is increasingly common now. So this is the start of the procedure, and I did this procedure with my colleague, Dr. Koo Chie Yang, who unfortunately is not here today. But you can see that this is a setup shot, and what you see here is that we couldn't actually cross into the distal LAD. This was actually a CTO, and we actually had to use a CTO wire to cross on the distal LAD, and thereafter exchange it to a workhorse wire. So then the question comes to, all right, if we're going to treat this LAD, where are we going to treat to? Are we going to just treat the proximal segment, or are we going to also treat the distal segment? And if so, what are we going to do? So the concern originally was if we just leave the distal segment alone, even if we actually improve the proximal segment, we were concerned about the outflow. So we decided actually to intervene the distal diffuse disease just to improve the outflow and minimize the chance of actually proximal stent complications. So maybe I could just pause here to just ask the panel, would any one of you consider treating also a distal LAD lesion, or would you just leaving it alone?
Fauzi, what do you think?
Yeah, I think we have to treat the distal lesions here. But whether it is should be stent or stentless artery, it is another issue.
Yeah, good point. What about you, Virash? Would you stent?
Also agree that difficult to select a stent. Maybe I will treat with a drug balloon if possible.
Yeah, so that's exactly our thought too. So, because otherwise it's going to be a full metal jacket of the LAD, which we were really trying very hard to avoid. So that's what we did actually. So having crossed the lesions and pre-dilated it, we decided to actually just treat it with a drug-coated balloon. In this case, we're using the Asian drug-coated balloon. So it actually expanded quite well after some lesion preparation with a 2 millimeter diameter balloon. So this is a 2.5 millimeter 30 drug-coated balloon. And so we treated the distal LAD, and the results were satisfactory, which I will show later. So you can see from this steel panel that we've decided that we're going to upfront use rotablation. Clearly, the very extensive calcification will require some form of plaque modification. And we decided that upfront, we're going to have to prepare the lesion just so that we can use subsequent devices and also intravascular imaging. We didn't think that we could advance any intravascular imaging device with that tight stenosis. So this is a 1.5 millimeter burr that we use to basically first prep the LAD lesion. And you can see that there was originally quite a bit of resistance trying to cross that very tight stenosis. So after several passes, we managed to cross it. Let's just try and forward a little. Yeah. Okay, what I'd like to highlight here is that you can look at the ECG. The patient developed actually marked ST depressions with the use of rotablation. And that is something to be expected, I think, with rotablation because of the issue of distal embolization. And the operators would actually have to be prepared to intervene if necessary if the patient develops hemodynamic instability. So fortunately for us, the patient's blood pressure was very high when we started off with, and after some brief rest, he actually tolerated the procedure well. And then we next proceeded to intravascular imaging. So the purpose of this is, number one, to define the extent of lesion. Number two, to define how much calcium there is. Number three, whether we have already done adequate lesion preparation and proceed to stenting. So I'm going to just now run the IVUS from the distal LAD. You can see that the distal LAD, there is some plaque, and you can see there is already some fracture of the calcium. And recall that there was a large proximal segment in the LAD. So I actually find this longitudinal profile very useful. It actually provides a good landmark to where you might be. And you can see here, just for the sake of those junior interventional cardiologists who might be attending session. So when you see this, it's because there's just so much calcium here. There's all these reverberation artifacts that you're not actually seeing anything because it's just 360 degrees calcium here. So you can still see it's very clearly very calcified vessel. So the rotablation really hasn't done very much to this lesion. So we're coming back now to the proximal segment. Again, there's apart from the little bit of a crack there, you have a full 360 circumferential calcification. Okay, so we're going to come back to the proximal part. So you can see largely untouched lesion. So there's lots of calcium still. Let me just try and go a little more. Yep, and these are representative steel frames from the distal coming back proximally. So distally, the vessel measures about 2.9 by 3. We take the EEL. And then in the mid segment, beyond the aneurysmal segment, at the luminal diameter is 3.5 to 3.6. And the osteo-LAD remains very tight. And this is the distal left main too. So maybe we can pause now and can get the panel to offer their take on how they might proceed now based on these findings.
Maybe you can ask our online panelist, Zhang Junjie, are you around?
Yes, Huaiqin, I'm around.
Oh, very nice. So Junjie, you may have seen the IVUS images. I know you have done a lot of IVUS trial. Do you think this is good enough lesion preparations for these patients before stenting, or do we need to do some more?
Yes, I think especially for a proximal, and I noticed there is a calcium broken. So for the very superficial and also round the arc, I think for me, before I put the stent, I still will use a big size balloon to the good lesion prepare further, because I noticed only one calcium broken. For me, for this kind of severe calcific lesions, at least 2 broken, I will put a stent implantation. Yes.
So you will take a larger non-compliant balloon to prepare the lesions further. Is that
Yeah,
correct?
yeah, or multiple predilation and long-time inflation. Yeah, get a good lesion repair.
But Fauzi, would you consider taking a larger burr? Because there's some part of it that still looks pretty concentric in terms of calcium, and that looks like not much of a luminal gain has been obtained, and also the calcium cap still appears to be fairly thick. Would you go upsize to a larger burr, or do you consider other form of lesion preparation?
Absolutely, I upsize the burr.
You will upsize
because
the
there's
burr?
a heterogeneous calcifications. At some part there is some crack, but the other still there, bulky of calciums. So moreover, the osteal part of the LED. So I'm thinking to upsize the burr, but
Good.
not until to distal part.
Okay,
Yeah.
so you targeted to the tight
Until
the part.
the mid-part.
Would you do that, or do you do scoring balloon or cutting balloon or whatever, or even orbital right now to achieve a greater reduction in the calcium?
Yeah, I think the IVUS still show a very high, circumferential calcification in both mid and proximal LD at the ostium. And by the angiogram, we also see that the quite heavy calcified. So I think better to modify praviti atherectomy, a bigger burr, or if you can achieve the orbital atherectomy, maybe it's better. Because I think the after you have choose the biggest burr you can get, then I will skip to the cutting balloon.
So rota orbit.
So
orbit.
so most of y'all will go for
I'm
bigger burr.
upsize the burr.
You upsize the burr. Actually, I was just looking at one of the trial that was presented at TCT this year called the COPS trial, where they use a cutting balloon to go really high pressure. You know, cutting balloon. I'm not a real believer of cutting balloon treating calcified lesions, but this trial seems to suggest that at high pressure, 16 atmosphere, it is possible to modify a calcified plaque and achieve a better stent expansion. But anyhow, to our agent, most of them want to go upsize their rotor burr to 1.75. What do you think?
Yeah, so I think those are good options. So in our case here, though, we decided that we're going to just use a scoring balloon. So in the case here, we first started off with using a Wolverine. This is a 3 millimeter Wolverine balloon to the mid-LED segment. And again, we can have a discussion of whether this scoring balloons actually have an advantage over just a conventional non-compliant balloon. And you can see that across the mid-LED,
How big is the balloon?
this is a 3 millimeter diameter, 3 millimeter by 15. So you can see that still some wasting in the proximal part. We just went up to the rated, which is relatively low actually for the Wolverine at 12 atmosphere. So, we try to keep with the IFU, although I have personally gone up to like 18 on the Wolverine, but sometimes it's better to stay out of trouble. So for this case here, I just went up to the rated 12, and there was still some wasting. You can see here, that's despite us having multiple inflations. Yeah. So we also went with another cutting balloon because we didn't have the available size for the Wolverine. We used a 3.5 Lacrosse. And this again was actually inflated to the rated pressure, and there was no obvious wasting seen. So this is a repeat IVUS after we have done further lesion preparation. So before I actually continue with this rest of the IVUS, I think a point here I'd like to make is after any significant lesion preparation, it's always good to repeat your intravascular imaging to know what you have achieved with what you had decided on. So if you had decided on using increasing size burr or orbiter, it's always good to just repeat it to see where you are now, and that will then guide you in the next step. So you can see that there are actually now more fractures resulting from the use of the scoring balloon. And at least at this juncture here, you can see that the calcium has been broken up into several pieces. So we're just doing a pullback. But down here, you can still see that there's still circumferential calcification.
But the lumen is pretty big, so.
Yes. I think we can have a discussion on whether increasing a burr size helps when you have large vessel, because some people say that you're only going to get as big as the burr, and if you have a 3.5 millimeter vessel, a 2 millimeter burr may not be of much use. So you can see that proximally there's still very extensive calcification, although in some areas you have actually areas of fragment. You can see this is a very nice trifoil fracture from the 3 blades in the Wolverine balloon. There is another lesion there. We're coming back now into the left main. So maybe we could take a pause here and discuss.
I must say that
what next should we do?
Yeah, I must say that the scoring balloon performed very well, because I don't see any residual waste and as he inflate the balloon. So it looks like whatever blockage or the calcified lesions that we saw didn't quite cause any significant residual stenosis. Seems like the balloon could easily overcome. While there's a lot of calciums going on still, but in the sites where there's still a concentric calcium, actually the lumens are pretty good. So as far as ischemia is concerned, it's not likely to come from there anymore. But where there were original tight stenosis, I can see that the multiple fractures occurring at the arc of the calcium. So question here is, are we all ready for stenting? Dr. Guoning, if you look at the IVUS, is there anything else we need to do for this particular artery right now, or you think we can go and do stenting? Or?
Yeah, no, this is a very calcified vessel, and especially after the scoring balloon and distal to the aneurysm part, we still some part we can still very thick calcification lesion. So if I did this case, I properly used a shockwave balloon and to modify the calcified lesion more. And at this point, I don't think a rotor upsize the rotor will work, because the vessel size or lumen diameter is bigger than 2.0 millimeter. That's not easy to get rotor ablation works very well.
Quite a good, very good suggestion indeed. If you look at the second, the top right IVUS image is still fairly concentric, although there's some suggestion of fracture at 11 o'clock. So Dr. Guoning suggests shockwave lithotripsy. Viraj, do you agree that we should go now and do shockwave, or before we stent?
Actually, we do not have a shockwave now, and I have no experience about the shockwave, because this is a lesion that already prepped with some kind of balloon before. In the IVUS, I think there are still some questionable undilatable lesion. For me, I will compare the angiogram with the IVUS first, and then if still some quite marked recoil of this diameter of the artery, maybe I will prep further with the NC balloon. In our center, we still have the OPN balloon that we can use instead of the IVL. It can get the very high pressure up to about 40 to 50 atmosphere, which I think that the mechanism is quite like the IVL. So that's my choice.
So OPN, higher pressure balloon, shockwave. Fauzi, what would you do? Are you happy with this IVUS, or you want to?
Yeah, I think this lesion needs further preparations. So based on the balloon that already looks open up, but we have to see from the orthogonal view, because some part there is something, there is no waste, but the other view, something still waste there. So that's we have to be careful for such informations from the angiography. That's why the imaging inform us that it needs further further pre-dilatation, or I think still need more atherectomy. I think still I'm thinking that we need upsize the burr. Because, this is not only modified, but the debulking. We need a debulk, the more debulking. Of course, the proximal part, maybe the balloon is going to work, the lithotripsy is going to work, but I'm afraid that but at the mid part is not work.
Indeed, there's many ways to skin a cat, I always say. So we have shortwave, we have OPM balloon, we think upsize. So agent, go ahead, tell us what you do. Did you take an orthogonal view? Was there any other view to suggest a residual waste? Or are we ready to do something else?
Yeah, I think there were very important points that useful and which were brought up in the discussion. I think first of which, as Fauzi mentioned, that in complex lesions like this, you can be fooled by using just angiography because the lesion might be eccentric, so from a particular angle, you might not be aware that there is actually still a significant wasting of the balloon, which you don't see. So if you do not actually use intravascular imaging, you may not actually appreciate this unless you have adequate views. Now, the value of intravascular imaging is that it allows you to actually define the lesion, whether you have adequately cracked the calcium, and whether further lesion preparation is still necessary. And I think the general consensus is that although we have already done a lot of work here, we started off with using rotablation, we have used a cutting balloon, it still is not good enough. And I think the consensus is that we should still do more lesion preparation. Now, before we proceed, I think maybe you could just ask Fauzi. I think you put out a good point about debulking. Yeah, well, rotablation is not usually a device that we consider as a debulking a lesion. I think we all do agree that it's excellent in shaving off the plaque. But in this case here, I think one of the concerns was that further rotablation might cause more ischemia. Because remember, in the initial run, the patient had marked ST depression. So I think the problem with rotablation is that whatever you debulk is not going to come out of the vessel. It's just going to go downstream and clog up the capillaries. So that was also another consideration why we did not upsize the burr, and we proceeded instead to just using a balloon angioplasty. So we were also actually in line with Dr. Guaning to decide to use intravascular lithotripsy. And we'll show you what we did next. Okay, so we proceeded to intravascular lithotripsy. And this is the 3 millimeter, no, this is a 4 millimeter by 12 intravascular lithotripsy balloon. I know it might sound weird that why are we putting a 4 millimeter balloon in the mid-LAD? So let me just pause and just explain. So the intravascular lithotripsy balloon, as you're all aware, is a very bulky balloon and is very expensive. Of course, we could actually use more than one, but it adds on to the cost for the patient because it's expensive. So what I sometimes do is to use what I think is going to be most useful in this application. And in this case here, it's going to be the proximal segment. And we had actually on intravascular imaging determined that the proximal lesion is a huge vessel, 4 millimeter and more. So we decided we're just going to inflate at low pressure. So basically, we're using this 4 millimeter intravascular lithotripsy balloon at a mid-LAD at maybe like 2 atmosphere. So certainly it's not a 4 millimeter expansion. And then we just applied the pulses. Now I think, one of the, let me just try and get back here. So I think while loading this, one of the concerns with the intravascular lithotripsy is how should you apply this the pulses. So I think it's important for people who are starting to use it that the balloon has to be opposed against the vessel. So you really should try and size the balloon to the size of the vessel. And basically the pulses are only delivered when your balloon is actually opposing the vessel. So if you actually have a 4 millimeter vessel and you just have a 3 millimeter intravascular lithotripsy balloon, you could deliver all 80 pulses and nothing's going to go there. Okay, so it's important that you actually have the balloon opposing the vessel, and for that you have to adequately size the lithotripsy balloon. I think that's probably one of the challenges that I see with people who are just starting to use lithotripsy. They don't actually use a big enough lithotripsy balloon. So then we gingerly move back proximally, and you can see that sequentially the balloon gets bigger because the vessel is bigger until the proximal part of the LED. This is like 4 millimeters. So you can see that it's actually, it can be expanded significantly at the high pressures, and we went up to the rated pressure of 10 atmosphere. So just caution that if you're using an oversized balloon in the mid to distal vessel, you just have to be very careful. You don't go too high because you run the risk of causing a vessel rupture. So just caution, okay? So this is out of the IFU. Of course, the company would prefer that you use multiple IVLs, but that's going to add on to the cost. Again, this patient has already had incurred significant costs from rotablation, IVUS, as well as the various scoring balloon. So cost is an important consideration in the real world. So we're going to now, this is intravascular lithotripsy. We're going to repeat the IVUS. I'll show you what the IVUS imaging shows like now after we have done further lesion preparation. So this is the distal part. You can see that you have clear fracture of the calcium plates. So while you can still see the circumferential calcium, you can see that there are areas of fracture along the vessels. And this is really what you want to achieve. Because if you do not achieve adequate fracture of the calcium, you're not going to be able to expand the stent that you plan to deploy. So the vessel is actually huge proximally. That's the osteo-LED that we started off with. And you can see that although there's still a lot of recoil here, you can see that there is multiple areas of fracture. That's the distal lap main. Okay, I think at this juncture here, maybe you could just get a consensus whether everyone in the panel thinks that we have done enough lesion preparation and we should proceed with stenting.
Jinjie, what do you think? Enough, or do you want to do some more of lesion preparation?
Yeah, I think after shockwave lesion prepare, I quite satisfied the result. I will put stent. Yeah.
Okay. Everybody agree? Ready to stand, or you want to do some more?
No, I think it's already we can start to stenting.
So we think
I'm thinking that this calcification is just for the rich persons.
Yeah, I think, yeah, so that's what we did. So this is the post preparation. You can still see that there's quite significant recoil, and I think this is where you really need to use the stents now to keep the vessel open. So that's what we proceeded to next. So to remember that this is actually a rather diffuse lesion. So we proceeded to stenting the mid-LED with a 3.0 by 32 millimeter synergy stent here. And actually, you can see that the stent expands very nicely, which is what you would expect following adequate lesion preparation. You can see that this is just at nominal pressure. It's very nice expansion of the stent, which is what you want to achieve. And then we have another stent more proximally. So, the proximal stent, we decided to use a Megatron, because one of the advantages of Megatron is, as Hui Jim has mentioned this morning, that it is actually designed for use with the left main. And especially when you have a huge discordance between the end vessel and the left main, this is actually a good choice because of its expansion limit. So that's what we decided, because the left main clearly was a huge vessel, and this is the Megatron there. And it's actually quite radio opaque, so placing the stent was actually quite straightforward, and we aligned it just with minimal stent overlapped with the distal stent. So again, you saw how easily the stent was expanded. And following the stent deployment, we proceeded to post-dilatation, as is usually required, using the 3.5 millimeter balloon distally, as well as a 5 millimeter balloon proximally. So I'm going to just show you how it looks like now after the stenting procedure. So this is the distal segment. You can see that the stent struts are coming up here. We don't have any edge dissection. You can see that the stent expansion is also fairly symmetrical. Of course, there are some areas that didn't expand as well, but I think given the amount of calcification, I think this is actually very reasonable results. What we want to achieve is actually symmetrical stent expansion, and you can only achieve that if you have adequate fracture of the calcium plates. Otherwise, you're going to get an asymmetric stent expansion. Like in this frame here, part of it at the 8 to 10 o'clock position, but most of it is actually pretty well expanded and symmetrically. What you get is a circle, which is what the vessel should be. So we're coming back proximally now. That was across the aneurysmal segment, and this is the proximal LAD. Yep, and then this is also the proximal LAD, because we didn't, it was a very long lesion. So this is just a proximal run across the osteo LAD into the left main. So I think we were all quite satisfied with the results. I'm going to just show you the final angiogram. Okay, so I think that was the case that I had to share. Does anyone have any comments? Anything else that you want to comment on, Hui Jim?
Yeah, so I think that's a real wonderful case of systematic lesion preparations guided by intravascular ultrasound imaging. So going through every step of the lesion prep, beginning with rotor, then followed by NC balloon, cutting balloon, scoring balloon, and then followed by shockwave lithotripsy, looking at the entire anatomy of the lesions, and then guiding you along the way as you decide to do what's the next procedure. You can see that from the finals IVUS that the stent strut is almost like blinded with the calcium. You can't see where the stent, which is a stent strut, which is a calcium anymore. But one thing about in the calcified lesion is that sometimes you may not get your perfect circular symmetry that you're looking for. To me, what's more important here is the stent apposition as well as adequate MSA here. The good thing is that the symmetry index has not been shown to be associated with clinical outcomes difference. So I go for stent deposition, and I go for as good MSA as possible. I think using the right device is also important, particularly with the use of the Megatron stent here. So Megatron stent is different from the Synergy XD stent in that it is a stent designed with strength. It's meant to support calcified, tight, and osteostenosis. So this Megatron, as I understand, is a slightly thicker strut stent compared to the normal Synergy XD stents, about 89 microns, so plus about 4 micron of polymer, so it's about 93, so slightly thicker than the usual. But in terms of deliverability, may not be as good as Synergy XD, but it just gives you that strength and support that you need, particularly for complex calcified lesions. So that's my take for this lesions, and very well shown as well. Fauzi, anything to comment?
Yeah, very excellent result. Very beautiful. Congratulations. What is the importance? Dr. Adrian demonstrated how important is to prepare the lesion, especially these such a calcification lesions. So, and the result looks, we can see angiographically, and IVUS demonstrated that the result is acceptable and beautiful. Thank you very much.
Thank you.
Viraj, any comment?
Yeah, I think that this is a very beautiful case to show that the stepwise IVUS evaluation, each step of the lesion preparation, you can see the chain of the lesion modification by every step to select the next device or the next strategy, and this is the must do to achieve the excellent result, I think.
Finally, maybe we can ask Dr. Guo Ning. Guo Ning is all the way from Xi'an, Shanxi province. We don't have a chance to meet you in person, but we're really happy for you to be joining us online. So do you have any final comments on this case that's been shared by Adrian?
Yeah, this is a very beautiful case. And from this case, we can see if we want to use IVUS guidance, we should use it during procedure and post, not only the post. That's a first point. And second point is for the patient with CKD, you can use IVUS to minimize the use of contrast. That's it. Thank you.
Thank you. So, Adrian, do you have any final words? Do you want to?
No, I think you've said it all. Thank you.
Thank you very much, Adrian, for sharing with us again. So, in the next segment, I'd like to invite Dr. Zhang Junjie, all the way from Nanjing People's First Hospital, a place that I almost visited every year until the COVID strike. Dr. Chan was previously a fellow with us. Now he's really an accomplished interventional cardiologist working in Nanjing. And he's obviously a PI of many of the trials that have been presented at various international meetings. And today we are happy to have him to speak to us on zero contrast PCI with imaging, obviously something very relevant, especially for patients with severe renal impairment. So, Dr. Zhang Junjie.
Thank you very much. Thank you very much, Huaiqing's kind of introduction, and also thank you for inviting me for this important session. Today is my topic about the zero contrast, or we can also say ultra low contrast PCI with IVUS image. Next slide, please. I have nothing to disclosure. Next. So today's my outline includes 3 parts. The first part is the CKD and the coronary artery disease. Next, please. So we all know so far we have solid data confirm that CKD is a very strong independent factors of the CVD. And also with the development of CKD, we also can show there is a high risk and increased risk of the factoring rates of the CVD events. Next. And the incidence of the CKD in PCR, this is the data from our ultimate trial from the CKD subacute analysis we can see the CKD incidence is about 10 to 24%, depending on the different formula used. If we use MDRD equation, there will be 10%. If we use CKD-PI equation, there will be 12. If we use CG formula, there will be up to 24% of CKD in ultimate trials. Next slide, please. So for CKD patient underwent DES implantation was associated with a significantly high risk of 1-year TVF. Compared with a non-CKD patient, the TVF increased up to 2.3 folds, which was mainly caused by a high rate of cardiac death, increased by 4.4 folds. Next, please. So the incidence of the contrast-induced AKI in PCI is not so rare. It ranges from 3.3% to 14.5%. And also we can see the CKD contrast-induced AKI associated with the high cost and the high dialysis and the high rate of cardiac death at a long-term follow-up. Next, please. And in terms of the pathophysiology of contrast-induced AKI, there is 3 parts. One is contrast medium can release of endothelium and adenosine, and also a decrease in nitric oxide, which will cause vasoconstriction and also cause ischemia of the outer medulla and the generation or reaction of oxygen species, which will finally induce the contrast-induced AKI. And also for the contrast medium and cause a direct toxic effect, where cause ischemia of the tubular cells. Next. So far, the only data supported measure to decrease the risk of CI-AKI is normal saline hydrations. Actually, we can use LDDP to guide its normal saline hydrations. Another useful method is to decrease the contrast volumes. So at this time, we can use IVUS or FFR to reduce the contrast consumed during the PCI, especially for the CKD patient. Next. So the next, the outline is IVUS-guided PCI in the CKD. Next. So far, we have 9 randomized studies comparing IVUS versus angio guidance DES implantation. Next. Ultimate trial is randomized studies comparing IVUS versus angio guidance DES implantation in glaucoma patients. At 1-year follow-up, the IVUS guidance DES implantation was associated with a lower rate of TVF, 2.9% compared to 5.4% at 1-year follow-up. Next. So we also extended the follow-up to 3 years. At 3-year follow-up, IVUS guidance DES implantation sustained the benefit over angio guidance, 6.6% versus 10%. Next. At subcutaneous analysis, you can also notice that in terms of a CKD patient, the IVUS guidance was sustained the benefit over angio guidance. Next. This is our CKD group of the sub-analysis of the ultimate trials. You can also notice that in CKD patient, if we use IVUS, which will definitely reduce the TVF 6.65%. Next. So in terms of Mozart randomized trial, it's the first randomized studies. Although the sample size is not so large, only 84% patient was randomized either angio or IVUS guidance. So compared with the angio guidance, the IVUS guidance consumes significantly lower of contrast, only 20 cc compared with the 64 cc in angio guidance. Next. And the other RLEs proposed the first pilot studies, totally included 31 patients with advanced CKD, EGFR only 60 millimeter, And the zero contrast PCR use the IVUS guidance with the pre and the post PCR measurement, and also use the FFR and the CFR guidance. All the PCR was successfully performed with no MACE. And also there is no renal disaster at a follow-up of 79 days. Next. This is also a multi-center register from Japanese colleagues, totally included 184 patients. So the inclusion criteria, including the patients with CAD and also elective PCI with end stages CKD patient. Exclusion criteria including hemodialysis. And at 1 year follow-up, you can see compared with the angio guidance, IVUS guidance was associated with a significantly lower of the contrast-induced AKI, only 2% compared with 50% at the angio guidance. Next. This is another prospective single-center study for a Japanese group. Totally 81 patients was included. And the Japanese colleague performed success non-contrast PCI in 90% of cases. And contrast-induced AKI only 5% without procedure complication. And after analysis shows a successful non-contrast PCI was inversely associated with worsened renal function. Odds ratio only 0.28 after adjusted renal function. Next. This is a new technique proposed by United States colleagues, which means coronary stent position under the live IVUS guidance in low contrast PCI. It's a very beautiful technique, but which need a larger guiding cassette, at least 7 or 8 French, depending on the different brands of IVUS cassette. During the stent depletion, simultaneously use another wire with IVUS side-by-side guidance the stent position. Next. So this is also another register for the Japanese group. Totally included nearly 700 PCI cases. Finally, we got 15 pair of PCI group. One group is zero contrast PCI group. Another group is convention PCI group after propensity score match. Next. So this study to get a long-term follow-up. You can see at a 3-year median time follow-up compared with convention PCI, zero contrast PCI shows the efficacy and the safety. In terms of MACE rate at a 3-year follow-up, there is no any difference. Next. So this is a pathway for ultra-low contrast CAG or zero contrast PCI proposed by Ziad Ali. Actually, firstly, we should identify a high-risk patient. EGFR less than 45 milliliter with diabetes, or EGFR less 30 millimeter should be considered as a high-risk patient. Then for this patient, we should consider ultra-low contrast angio with LVDEP guidance. And also we should minimize the contrast volumes. So after the angiogram, for the stable patient, we should consider stage PCI at least 1 week later. If we perform this PCI, we should also, with LVDEP guidance hydration with normal saline, and during PCI, we should use intracoronary imaging, especially IVUS, pre and during and post PCI to guide the DS implantation to minimize the contrast volumes. Next. So let's have a take-home message. The incidence of contrast-induced AKI is particularly in advanced CKD. CI-AKI has been associated with increased hospital stay and costs, and irreversible kidney injury needing dialysis and death. The mainstay of decrease of CI-AKI risk rely on the minimization of contrast volumes. Zero contrast PCI is safe and feasible in selective coronary anatomies by IVUS guidance without compromising the residual kidney function. Thanks for your attention.
Thank you. Thank you very much. Testing. Thank you. Thank you very much, Jin Jie, for your lecture. And I think all of us agree that zero contrast PCI is something that is feasible and safe based on what you have presented and sharing with us the literature. And to me also, the zero contrast PCI or low contrast PCI involves heavily a lot of imaging guidance during the PCI itself. Most likely going to be intravascular ultrasound, but if you insist on OCT, it's going to be a saline sort of flushed OCT imaging. And plus many other small little techniques such as was outlined earlier on. I think importantly, we want to separate the diagnostic procedure from an intervention procedure so that during the PCI itself, you don't have to go through the whole thing again. Secondly, if you have a biplane machine, I think that is very helpful because one shot you can have two images and so forth. Otherwise, you probably just should take the one view. Thirdly, I'm actually quite intrigued because I have seen Ziad Ali demonstrating when you try to engage the coronary osteum, you take saline and then you look for this ECG ST elevations, so that you don't use contrast to test for your engagement, but you use saline and using the ECG as a guide. So I thought that was a pretty ingenious technique as well. And the other thing, two aspects, of course, is the hydration part as well as the contrast volume part. So I'm going to ask my panelists here. So in your practice, what sort of hydration regimen do you use and to ensure that the patient is well hydrated? Because he uses Poisson protocol, which can be a little bit laborious. So you got to go and measure LVEDP and you're going to titrate your fluid and so forth. So what sort of a hydration regimen would you recommend in your practice for a patient?
Yeah, for my practice, I think that it's up to the LV function of the patient as well, because in some patients who have a lower ejection fraction, sometimes you have to limit the fluid intake. So in our protocol, the standard protocol, we give about 40 milliliter per hour of the saline, at least for about 12 hours before the PCI or the intervention. And then after that, we continue the saline for 24 hours in this rate and try to monitor the fluid.
So 12 times 50, around about 50 will be about 600 cc over 12
500
hours.
cc.
500 cc over 12 hours. Agent, what would you say as far as your hydration goes? That means you have to admit the patients the day before.
Yeah, I think as Viraj mentioned, I think it depends a lot on the patient's renal as well as cardiac function. So for those who can actually tolerate a volume load, I would actually just give them lots of hydration. Yeah, so I think hydration, there's no downside to it, unless the patient has poor heart function and renal impairment, then you run the risk of going to heart failure. Yeah, so at least what Viraj has mentioned, sometimes 2 or 3 times higher if the patient's heart function tolerates.
So Fauzi, is saline flush OCT imaging something you do to reduce the contrast if you insist on using OCT for patient with renal failure?
Yes, I saw this morning from the Hong Kong live. It is very, very beautiful, just using saline for the OCT. But as discussed, that it is important just to use silent in the RCS, not to the LED. LED you can use half saline and half contrast. So yeah, that's.
Do anyone else have any tips and tricks on reducing the amount of contrast used in the course of your PCI? Ziad, to take 3 cc, he does a 3 cc first shot and 3 cc's final shot, and that's it, 6 cc for a PCI. So what sort of tips and tricks do you would like to share with us in terms of reducing contrast?
Antonio Colombo said the contrast should be used not to be safe. That's important message given by him. I think zero contrast or low contrast is for the peak of the pyramid of the operators who has skillful, very skillful, and get familiar with the imagings, not for all the operator. So the message is how to use contrast wisely. That's what I'm thinking about.
Any tips and tricks on reducing
Yeah, I think for those of you who would want to use OCT for your imaging, I think one way of reducing the contrast is to basically coincide your angiograms with the OCT runs. So that way, you don't actually have to do extra imaging and contrast use. So for example, if I were to do a stage procedure and I had a prior angiogram, I would actually just print out those pictures, put it in my lab, and I may not actually even need a guide shot prior to the procedure. And so my first shot of the lesion might be the OCT run. And with a biplane room, you basically can actually save quite a bit of contrast that way. And for post-procedure, that might really just be my final angiography images, the OCT run, because what more do you want to see besides without the catheter? Because with the OCT imaging or any intravascular imaging, you're already seeing a lot more than with the angiogram. Yeah, so I think just timing it, would be one way of minimizing the contrast.
Another way is that try to use some modalities such as the stent boot or the auto road map to help you guide the positioning of the stent. Since the stent boot also shows some enhanced calcification, which I can use as a landmark. The other point that I try to teach my fellow is that try to control your manual injection of the contrast. Since we were taught to be used about 7 cc of contrast for left and 4 cc contrast of the right. But actually, when I try to control my hand injection, I can make an angiogram that can guide the PCI with the 2 cc for the left chorioid and 1 cc for the right chorioid. So if you can control your hand regularly, you use less contrast.
Junjie, do you have any tips and tricks on how you reduce the dose of contrast in the course of your PCI for patients with kidney failure?
I think the most important things, I think, to evaluate the CKD stage, especially for 4 and 5 end-stage CKD for this kind of patient. For me, I think I'll definitely use IVUS guidance. And during the procedure, I was actually it's impossible to do the zero contrast. I will dilate the contrast to a small test and during the procedure stepwise with the IVUS guidance. And finally, I will do the final shot, maybe less than 10 to 20 cc for one PCI.
Yeah, I agree with you. It's quite impossible to have no angiogram, otherwise what is there to show? But contrastless maybe should be pronounced as contrast-less angioplasty. And so I do have actually a very simple guide formula for myself. If you have GFR, I'll multiply by your GFR by a number of 2.7, and that will be the maximum contrast that you should allow yourself to use in the course of PCI. So simple equations that I use it for my daily practice. So with that, I really like to thank my two speakers, Dr. Guo Ning and Dr. Zhang Junjie from China, as well as Dr. Adrian Loh here for sharing a wonderful case of image-guided PCI of a very complex calcium lesions. I think we all have certainly fulfilled the learning objectives that we set out to be. It's really to learn all the various techniques of IVUS guidance and the ways to modify a plaque. So I'd like to thank the audience here, besides also my panelists here, for participation in these sessions. Actually, the meeting is not over yet for today. There's also a medical paper writing workshop, which I really will encourage you to attend. It's very well run. And so thank you very much for joining us in this symposium, and I hope that you enjoy the rest of the meeting and the evening as well. Thank you.